Good afternoon. Hello, everybody. My name is Joe Peak. I'm the JBLM Joint Base Installation Public Affairs Officer, and thank you for being here this afternoon for our fourth and final Ebola virus disease town hall meeting. Thank you for taking time out of your afternoon. Just a couple of administrative notes before we get started. First of all, soon General Lanza is going to do some opening remarks, and then Lieutenant Colonel Rod Markham from Madigan will be doing our couple of slides briefing here about the Ebola virus. And after that, we'll have a question and answer session. So during Colonel Markham's briefing, if you have any questions, just make a note of those to yourself. And then we've got the microphone right here in the middle. Feel free to walk down and ask your question. Just so that you know, this town hall is being streamed live over the internet for those who couldn't make it here today. Later today, we'll put links for all four of the town halls that we've done here at JBLM up on the JBLM Facebook page. So we've got those all recorded. And I think those are all of my important notes other than go Hawks. All right. Okay, you know where my loyalties lie. All right. And here's Colonel Hodges, Joint Base Commander.
As Joe said, thank you all for joining us today. And this is our fourth one of these. And I want to emphasize this is all about education and information and full transparency. And so we have the experts up here today. They can talk about Ebola, and Colonel Markham does a fantastic job of that. And any other questions you may have about what's going on here at JBLM in terms of the missions we've got going on here and Ebola in general. So if you walk out of here today and you don't have 100% of the information you want, then shame on you, okay? So we're going to have all the experts here to answer the questions, and come forward to ask anything that you want to ask about Ebola, because again, we've got the experts. And speaking of experts, I'm now introduced to you Lieutenant Colonel Markham to talk about Ebola virus.
Well, on behalf of all the senior leadership at Joint Base Lewis McChord, the hospital commander, and the entire Madigan healthcare team, I want to thank you for allowing us to join and engage in a dialogue about Ebola virus disease. So my name is Rod Markham. I'm one of the hospital's preventive medicine physicians and the hospital's public health emergency officer. And in that capacity, over the past few weeks, I've been working with a very large team to synchronize our efforts with local and state public health officials to make sure that our Ebola response plan fits well within the construct of the guidelines from the Department of Defense and the Centers for Disease Control and Prevention. What I'd like to do for the next few minutes is summarize some of the key points about Ebola virus and the disease it causes in humans. I'll highlight some measures that are preparing and protecting our service members as they prepare to go downrange to West Africa in support of Operation United Assistance. I'll highlight what Madigan has done to prepare its facility and staff in the highly unlikely event that we actually have to care for a potential Ebola virus patient. Then lastly, I'll talk about what we can do together moving forward. So since its identification in 1976 along the banks of the Ebola River in the Democratic Republic of the Congo, the Ebola virus has led to approximately 24 small outbreaks, or what we refer to as clusters. These clusters occurred in Central Africa. The region in Central Africa is largely inhospitable. There's not a lot of it's sparsely populated, relatively inaccessible, and so these small clusters were generally self-limited and didn't tend to transfer between villages. Approximately 7 months ago, we started to see cases in West Africa for the first time. And that's significant because the infrastructure in West Africa is much more robust. There are a lot of roadways, much more accessible. There are transit points, airports, ports, and most importantly, there are large urban population centers, densely populated areas. Unfortunately, over the subsequent 7 months, we did see cases get into these large population centers, and as a result, we've seen the largest outbreak of Ebola virus to date. So Ebola virus itself is a significant hazard, but there are several vulnerabilities of the virus that we leverage to implement very rigorous public health control measures to help stop its propagation and prevent further spread. One of the most notable weaknesses or vulnerabilities of this virus is that it is relatively difficult to transmit between humans through routine, casual interaction. In order to become infected with Ebola virus, You have to come into direct contact with the blood or body fluids of somebody that is infected and symptomatic. And that contact has to occur over skin surfaces that are not intact, meaning they're abraded, cut, scraped, etc., or through exposure to mucous membranes, things like your eye, your nose, or your mouth. Ebola virus is not spread through the air like the common cold or influenza virus, nor is it transmitted through the bites of insects like mosquitoes, fleas, or ticks. And you can't get Ebola virus through the consumption of usual and customary food or water sources. A great example of just how challenging this virus can be to transmit between humans through routine casual interaction can be seen in our own country. In Dallas, Texas, a couple of months ago, an individual, a Liberian national, returned to the United States, stayed with family. He stayed in a relatively small apartment with 4 individuals, 2 children, 2 adults. Over the approximately 2 weeks he was there, he developed symptoms consistent with and subsequently documented to be Ebola virus disease. He had nausea, vomiting, he had a lot of diarrhea. So this is a very highly transmissible point in his infection. However, over the 5 to 6 days when he was very symptomatic and living in this small apartment, he did not transmit that virus to those 4 people, and none of the individuals that lived in the close quarters with him went on to develop Ebola virus disease. Ebola virus disease is a very significant health hazard when it's contracted. To this point, we do not have any FDA-approved or licensed vaccines or treatments for the virus and a disease it causes. There are some investigational agents that are used if they're available and appropriate, and there are several good vaccine candidates, but to date, none have been approved. So what we do is we provide very early and aggressive supportive measures. And those supportive measures take the form of rehydrating them, providing them fluids to match their losses through diarrhea and vomiting, preferably orally, but we can also provide intravenous fluids if required. We monitor salt balance in the blood and replace electrolytes if it's required, and provide supplemental oxygen if it's necessary through their disease process. Again, these early aggressive supportive interventions have proven to reduce mortality. On Tuesday, a physician that was diagnosed with Ebola virus disease and treated for 3 weeks using these measures was released from a New York hospital. He is the 3rd of 4 diagnosed cases in our country to survive the virus as a result of these early and aggressive supportive interventions. So one of the take-home points that I hope you leave with today through this discussion is that first bullet. There is a very small subset of our population that is risk for Ebola virus disease. And those are specifically individuals with an appropriate travel history, meaning they've gone to one of the 3 countries in West Africa that have ongoing transmission. And those countries are Sierra Leone, Liberia, and Guinea. And so this allows us to identify those that are at risk for subsequently developing the disease. To do that, we look for specific symptoms. And this is one of the challenges with this virus because a number of the symptoms that Ebola causes are also very common with other diseases you can encounter through travel to West Africa, things like malaria or dengue fever. And unfortunately, this time of the year in the Northern Hemisphere, they also look a lot like the influenza virus. And so that also adds a degree of difficulty. Those symptoms are low to mid-grade fever. Individuals often complain of a headache, body or joint aches. They develop an upset stomach that leads to nausea, vomiting, and diarrhea. And so as clinicians, we really want to pay attention to that small subset of our population that is at risk for developing Ebola virus disease and look for symptoms and take appropriate actions thereafter. So Operation United Assistance is the Department of Defense supporting effort to other governmental organizations, and in this case specifically USAID and other non-governmental organizations to really increase the capacity in West Africa at the source of the outbreak to help those NGOs and USAID and the Public Health Service be able to identify, resource, treat, and contain the Ebola outbreak. Again, DoD personnel are in a supportive role, and no DoD personnel will be providing direct care to diagnosed Ebola patients. And every effort is being made to reduce the exposure potential to all service members deployed in support of Operation United Assistance. Before they go, they get very extensive briefs on the health threats common to West Africa. Some of those health threats include the environment itself. Currently, temperatures are in the upper 80s to low 90s with very high humidity. There are a number of vector-borne illnesses. That's a fancy word for mosquito-borne diseases, things like malaria and dengue fever. We spend a lot of time talking about protective measures to prevent those mosquito-borne illnesses, like sleeping in bed nets, protected uniforms, using bug repellent or DEET when appropriate. And we do spend a significant amount of time reviewing the signs and symptoms of Ebola virus, the appropriate forced health protection measures to implement to avoid or minimize the risk. We talk about the monitoring that they undergo when they're in country. Every service member in West Africa has twice daily health checks. Those health checks are basically account for a temperature and then a symptom review to make sure that they have not developed or any concerning signs or symptoms. And then lastly, we provide them with an opportunity to do hands-on practice with their duty-specific personal protective equipment so that before they leave, they're comfortable with taking off their duty-specific equipment. Nearly all service members that will be returning from Operation United Assistance will undergo a 21-day controlled monitoring at a pre-designated Department of Defense installation. And really what this 21-day controlled monitoring amounts to is just an extension of that monitoring that they were undergoing while they were in country. Again, they'll undergo twice daily health checks, their temperature will be measured and recorded, and then once they complete that 21-day monitoring and they're medically cleared, they'll return to their home station for completion of redeployment and the start of reintegration operations. So Madigan is prepared in the unlikely event that we're asked to either care for or diagnose a potential Ebola virus patient. The hospital, its outlying medical and dental clinics have instituted universal screening precautions aimed at identifying that small subset of our population that is at risk for developing Ebola virus disease. Our frontline clinical and clerical staff have been trained on identification of the signs and symptoms of Ebola, the initial appropriate actions to conduct a more enhanced screening. We've identified locations in each clinical care area to do segregation and isolation if it's required, and stock those locations with the appropriate personal protective equipment. Should somebody require admission to our hospital for either diagnosis or treatment of Ebola, we've trained now over 80 personnel of various types, lots of different types of nurses, physicians, clinical support staff, operational support staff, and I think yesterday our first chaplain. So we've looked to make sure that we've garnered all of those assets that would be important in providing that early and aggressive supportive care. So this slide allows me to speak to a bit of a transition period in our domestic response to Ebola. As of last Friday, we were 22 days out from the CDC's initiation of very rigorous screening for all individuals coming into our country from one of the three areas of potential transmission risk: Sierra Leone, Liberia, and Guinea. And what that allows us to do as a public health system is to identify people at risk, screen them early, establish their exposure risks, and then hand them off to the public health entity that will be following them for the subsequent 21 days, or the duration of the longer incubation period for the virus. And so we have a really good understanding of the small subset of our population that is at risk, and we can follow them and develop deliberate plans through daily interaction. And so it's really unlikely that we're going to see another episode of somebody coming to the country after high exposures that's not monitored daily, that develops symptoms and subsequently inadvertently exposes a large number of individuals. But as we move forward together, one of the most important things is if you have had an appropriate travel history to one of those three countries, or you know somebody that has, make sure to continue that dialogue with the public health authorities. And if you haven't had a dialogue, reach out through your primary care provider or through your local public health entity to begin that dialogue and assess your risk for Ebola virus disease. One way to get a hold of the public health authorities here at Joint Base Lewis-McChord is through the Preventive Medicine Department, the department which I work for. And that can be accomplished through your primary care provider or through the TRICARE Regional Appointment Center after identifying your travel history and concerns for Ebola. That's during normal business hours. If it's after hours, the main hospital line can perform the same linkage to preventive medicine assets here at Joint Base Lewis McChord. So that really concludes my prepared thoughts. It's exceptionally important to understand it is difficult to transmit through routine casual interaction. This virus is a challenge to transmit through routine casual interaction. Important to get early and aggressive supportive care, and that really a small subset of our population is at risk, and those are individuals that have traveled to specific countries in West Africa in the last 21 days. So with that, I think we are looking to entertain any questions or concerns you might have about Ebola virus disease.
So at this time, if anybody has any questions, you're welcome to come forward to the microphone here in the middle aisle, and either Lieutenant Colonel Markham or members of the command who are gathered here can try to answer your questions. Any questions? This will be the only town hall we've had no questions. Okay, then.
I have a question.
Okay,
Myself.
Lieutenant Colonel Markham has a question.
Who's that guy, right? So this is a question that's come up in 3 of the 4 town halls to date, and I think it's important. And that's the fact that we will have returning service members. And the use of the term quarantine, and that seems to be the framework where this question is posed. So we will have service members returning from Operation United Assistance, as I alluded to. The process that's been in place is done out of an abundance of precaution. If these service members didn't wear a uniform, got on a plane, flew into one of the 5 airports that the CDC does screening for, they would be identified as low but not zero risk. They would be handed off to a local public health entity that would undergo those daily health checks. This is a process that the DoD has instituted. This is not quarantine. It's a controlled monitoring. It's basically taking individuals and doing those health checks in a common location. So it's really important to understand that quarantine is not the case. It's actually just a controlled, a facilitated monitoring process.
Okay, any other? And that's great that Colonel Markham brought that up, because that has come up in each town hall. It's great to get that further explanation. Seeing no questions?
Sorry.
Oh, he's got one more. You know, there's always one in the
You
crowd.
think after 4 of these I'd have this down? I said nearly all service members returning from Operation United Assistance would undergo controlled monitoring. And the gentleman always tends to keep me in line. I made mention of the fact that I forgot to say, well, what about the other folks, right? So there are a number of individuals that are identified as transient, meaning their exposure risk is so low that they don't need to go through those 21-day controlled monitoring sites. And that's largely air crew, right? They land, they offload their equipment, they fly back. What they undergo is 21-day self-monitoring in conjunction with their unit-level medical provider and local public health agency. So everybody has a degree of monitoring. Not everybody does the controlled monitoring. If they're transients, they do it themselves. There's a plan in place. They talk to their unit-level provider daily, or 3 times weekly, and then public health weekly. So that's the other part of the nearly all service members. Anything else I've forgotten?
I don't know. Is there anything else that you've forgotten, sir?
Yeah. Man.
Okay, great. All right, then we'll wrap here with some closing remarks. General Lanza?
Joe, thanks. And I want to thank Chuck Hodges. I want to thank Dr. Markham. And I really want to thank the community and the Air Force for what we've done here to bring this together. And specifically, I don't know if there's any MWR reps here, but for what you've done to take care of those buildings, thanks. To the community at large here, this is really about information flow and it's about communication. So you may not have any questions today, but as this comes to fruition, as things come up in your mind, you saw the hotline up here, you have the subject matter experts of the community here in front of you. So I'd ask if anything comes up either with you or your families, either on or off post, that you leverage the capabilities and the expertise that we have up here. But this is about being transparent, as Chuck has said. It's about being collaborative, about open communications, so that we mitigate any innuendo, mitigate any type of challenges we have with really things that really drive the community to places we don't want to go because of our inability to communicate effectively. And what I have found with over 30 years in the military, our ability to communicate and be transparent, be first with the truth, and Joe knows this, is very helpful to all of us in here, both military families, our civilian counterparts, and those we work with in the community. So thanks very much. I want to thank Colonel Hodges and team, Dr. Markham again, our Air Force teammates that are here. We appreciate everything you do and hope everybody has a great weekend. Thank you very much.